Hello, magandang umaga, magandang hapon, magandang gabi po sa inyong lahat. Welcome to our 134th episode of Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and to all those who have just discovered us for today, welcome po. Sana po marami po kayong matutunan sa ating webinar topic. At some point in life, all of us will take a trip to a healthcare facility for emergency care. Usually, this could be due to an acute event that may be perceived to be life-threatening and requiring immediate attention. And over the past few decades, specialization in emergency medicine has grown and developed in leaps and bounds in response to a growing need in the Philippines. And an emergency medicine physician diagnoses and treats patients with critical illnesses or injuries, particularly trauma victims and patients with multiple organ dysfunction, who require care over a period of hours, days, or weeks. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday, and always looking forward to sharing hosting duties with our adjunct research faculty and our internationally renowned public health communication expert, Dr. Susie Pineda Mercado. Dr. Susie? You're on mute, ma'am.
Hi, Raymond. Good afternoon. Okay na. Okay, yes, hi, everyone. Good afternoon and welcome to the webinar. We'd like to greet all of you who are with us live on Zoom, but I'd also like to greet those who are watching us on TVUP YouTube channel, as well as the UP System Facebook page and the TVUP Facebook page. And of course, for those who are watching us on TVUP Signal TV channel 101. So we are on multiple platforms and here really to bring you the latest and the most, what should I say, the most recent updates on medicine and public health. Anyway, in this webinar, as Raymond said, we will hear the story of how the emergency department of PGH has evolved over 25 years. So they're celebrating 25th anniversary. And it will include some very practical tips on emergencies, commonly encountered cases, and an explanation of the range and scope of emergency medicine as a specialty. So we're going to have ako new generation na lahat to, Raymond. I'm so happy to have the next generation of really excellent physicians who are in this field. Dr. Marjorie CRUZ, Chief Emergency Medicine Specialist, and Dr. CHRISTOPER Manalo, Emergency Medicine Specialist, both from the Department of Emergency Medicine at the UP PGH Department of Emergency Medicine. And of course, the reactor will be your favorite, Dr. Ted HERBOSA, who is actually founded the Emergency Department, is current chair, actually coming full circle from beginning to now. And our closing remarks will be delivered by Dr. Leo CUBILLAN, who is currently advisor to the UP President for Academic Affairs and Research Development. So I know that all of you are looking forward to some news and some updates on medicine and public health. And it's for this reason that we bring you the news update.
Okay, for our very first news update, and this is something that you probably have asked yourself, why don't we have more of the vaccines po that target the fungi? We have marami po tayo for viruses po, no? But not really so much for fungal infections. This screen cap is from Vox, but this is really from the hit TV show from HBO, which is The Last of Us, and really going into baka pwedeng mangyari ito eventually if that's something that we're looking at. But fear not, Dr. Karen Norris, who is an immunologist at the University of Georgia's Veterinary School, has been leading a team developing a fungal vaccine candidate po, no? Dr. Norris's group, her group has developed a prototype targeting 3 fungi responsible for 80% of all infections in immunocompromised people: Candida, Aspergillus, and Pneumocystis. Ito pong prototype vaccine significantly reduced illness and deaths due to these infections in experimental mice and primates pa lang, but hopefully it's something that to look forward po, no? And a wide variety of other candidates are also being studied. So let's keep an eye out for that one. Dr. Susie?
Yeah, Raymond, from Reuters, bird flu has spread to new countries, and this now, threatens some kind of a nonstop war on poultry. On Wednesday, Argentina and Uruguay each declared national sanitary emergencies after officials confirmed the country's first infections from H5N1. And we talked about this last week. I believe we were reporting that in some parts of North America, there has been they have identified H5N1 in mammals. And so the World Health Organization is watching this, but now Argentina has found the virus in wild birds, while Uruguay has reported it in dead swans. So we will continue to monitor this situation, and hopefully it does not become something we don't want it to be, but we're monitoring this very closely. And that's our news for today. Next week, we'll be back with more news on the News Update. Okay, and we're back. Our topic for today is emergency medicine. And of course, in an emergency, time is of the essence. Hence, the key is to determine who can and cannot wait in an emergency room. Of course, it's very difficult when we bring somebody to an emergency room. Of course, we want to be, what should I say? Want to get attention right away. But sometimes there are different situations, and the key to a good emergency department is really the ability to determine who needs to be attended to first, who can wait. And so we have specialists in emergency medicine who are used to seeing these acute conditions and specifically applying what we call triage principles as needed. Assessing a patient requires careful observation, skills in physical examination, and sound and timely decision making. So, Raymond, I think we're going to ask some people persons on the street what their experience has been.
That's true, Dr. Susie. And this is for those who are joining us for the very first time. We usually set our discussion into context by watching a very short video produced by the TVUP team. The question that we pose to the common folks on the street po, no? Naka-experience na po ba kayo sa emergency department na isang ospital? Ano po ang inyong karanasan sa emergency department? Please watch this.
Anong nakaraan sa emergency ako?
Oo, naka-experience ako nung sinugod ako sa ospital na na-aksidente ako.
Yes po, naka-experience na ako. Nagpa-admit ako. And pag nandun ka na sa ER, i-ask nila ano yung nararamdaman mo, i-assist ka nila.
May na-experience kami one time. It's my brother, 5 years old. Inasma siya, then dinala namin sa ER.
Yung tito ko kasi nakagat siya ng aso. And then malala kasi yung kagat sa kanya ng aso. Like, parang ewan ko, malalim talaga. So parang we had to rush him sa nearest hospital sa amin sa province, which is a public hospital.
Isang beses, kaya lang hindi ko nagustuhan kasi masusungit yung mga nurse and doctor. Kaya etong nag-private ako.
Anong experience? Medyo maraming tao, parang pinaprioritize sila yung medyo malala. Kasi ako hindi naman ako sobrang lala, so pwede akong maghintay doon.
And then nandun kami sa ER. Then bago ka kasi ipunta sa ward, parang kailangan pa ng ang dami-daming information. So what if like super emergency case yun, and then sobrang dami nilang information na kinukuha, baka alam mo yun, hinugutan na ng hininga yung tao, and yet di pa siya na-diagnose ng doktor.
Asikasuhin ka nila kung saan ka dapat nila ilalagay or sino yung doktor na pwedeng tumingin sa'yo.
Nung pagpasok namin sa ER, hindi pa kami muna pinapansin. Then yung kapatid ko kasi nun parang hingal na. Then parang chine-check pa nila kung anong name, ganun.
Pero yung mga inuuna nila, yung mga dumudugo na talaga ng marami, yung nagdideliryo, yon yung mga medyo mas malala, yun yung inuuna nila. Tapos yung iba na, kagaya namin na hindi naman ganun ka lala yung injury, hindi kami nauna.
Sana priority muna nila and then saka na lang nila tanongin yung pangalan, information, address, or kung may health card muna. Yun.
So I suggest na parang before they get the information, yung mga needed information, parang i-check muna nila yung tao. I don't know. Kasi I'm not working in a medical field, pero from the point of view of a patient, of the relative of the patient, parang mas priority muna sana na i-check yung health ng patient.
Thank you very much. Thank you so much, TVUP. It's always good to hear how the person on the street sees the situation. And we've brought together some excellent speakers for you to talk about this field of emergency medicine. Of course, the issues around Raymond, yung expectations ng mga tao. No? People have expectations, but actually, they also understand when they see that, there are other people who are really in bad shape. Naiintindihan din nila, no? So anyway, we will talk about all of this in a while, but I think Raymond, you have some housekeeping first. Go ahead.
Thank you, Dr. Susie, and thank you for that really well, not really an eye opener, but something that continues to make sense to us, but really something also that will need to work on some more to make it better yung sa ating pagtrato sa mga emergency room patients. Okay, a little bit of housekeeping po, no? For those who are asking, certificates of attendance will be given to those who have watched at least 50% of the webinar duration. I see in the chat that there are those who are asking why they haven't received their webinar certificates for this year po, no? We'll check your the records for that one, and please keep an eye out for your certificates of attendance coming in from Stop COVID Deaths at up.edu.ph. For today's webinar, we'll be having a standard panel discussion format, and after our two presenters are presented, we will hear from our reactor, followed by a Q&A session po. But before we delve into the webinar, I know everyone is very excited about our fun quiz, so let's play our cute intro video for our fun quiz segment.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Naging rabbit, ano? Rabbit tayo doon, Raymond. Year of the Rabbit.
Yes.
Okay, game.
It's the Year of the Rabbit, Dr. Susie, di ba?
Kaya nga, oo, kaya rabbit tayo. Oh, game.
Okay, for those who are joining us outside of the Zoom, please open up your browsers and type in slido.com. And when you are prompted, enter the code 6510096. That's 6510096 for you to be able to participate in our fun quiz. For today's fun quiz, we have 3 questions po, no? We'll deal with our first question for today. It reads, a patient comes in with difficulty of breathing with respiratory rate 30, oxygen saturation 80%, and heart rate at 40 beats per minute, and fever. Ito po bang patient po natin ay makaklasify as option A, emergency severity index 1, which and he or she may die within minutes. Number 2, emergency severity index 2, may die within hours. Emergency severity index 3, need medical resource. And then option D, or pang-apat pong option, emergency severity index 4, need ambulatory care. Mayroon pa pala isa. Number 5, emergency severity index 5, no need for medical resources. So we see that there are those who are answering, at least in the Zoom po, no? And we'd like to take this opportunity to greet those who are watching us from the Ifugao State University Eye Center in Alfonso Lista, Ifugao, from the Malinao Treatment and Rehabilitation Center in Albay, the Tapas Municipal Health Office in Capiz, Vicente Soto Memorial Medical Center in Cebu City, Mayor Hilarion A. Ramiro Senior Medical Center in Osamis City, Misamis Occidental po. No? There are those who are watching us also from Bataan, from Iloilo City, those who are also watching us from the Icon School, Magsaysay, Alicia, Isabela, Alicia, South District Schools Division of Isabela in Regional Office of Tuguegarao. From Rizal Medical Center, meron din po mga nanonood. From Southern Philippines Medical Center, maraming salamat po. From the Air Force City Hospital, thank you so much for joining us. I think that's the first time that we're having them po, no? Thank you so much. From the National Teachers College din po, and others who are joining us from this webinar, Cebu Doctors University and Cebu South Medical Center. For our question number 2, po reads, a patient comes in due to motorcycle crash with protruding bone on the right leg with low blood pressure. The patient is classified as emergency severity index 1 po ba siya? May die within minutes. Or is it 2? May die within hours. 3, need medical resource. Number 4, need ambulatory care. And number 5, no need for medical resources. May pahabol po, greeting those watching us from the Napolcom. Thank you so much po. But internationally, we are also being viewed po by our avid viewers from the Chuanin Hospital in Taipei City in Taiwan, from Penang, Malaysia, from Hamad Medical Corporation in Doha, Qatar, in Dubai, United Arab Emirates, University of Hail, Saudi Arabia, Lunichi Ali University of Lida II in Algeria, and in the United States, Irvine, California. May mga pahabol din po from the University of Result System na nanonood po sa atin. And then finally, question number 3 for multiple casualty incident. Can we have it in Slido also? Number 3 po. Thank you so much. For multiple casualty incident with dozens rush to the emergency department using color coding, how would you classify a patient who is unconscious, active but has active bleeding and multiple fractures? Ano pong kulay siya? Black po ba siya? Code black? Is it code red? Is it code yellow? Or is it code green? Yan po ang inyong pagpipilian for the third and final question. We'll keep this open. Ito pong webinar fun quiz po natin po, no? As we move on to our webinar proper for today. Dr. Susie?
Thank you very much. And we're really looking forward to how our experts are going to answer these questions. Nakakatuwa rin na nagpa-participate yung ating audience, no? So it's a time to think and to refresh to jog your memory on what you learned in emergency medicine. But we've got some experts, and let's get this ball rolling. So our first presenter, she's a fresh face to our webinar series, but one of the rising stars in emergency medicine, chief of the emergency medicine department of PGH. Let's give a warm virtual welcome to Dr. Marjorie CRUZ. Marjorie, welcome to the webinar.
Good afternoon. Thank you for the warm introduction.
Okay. Sige. Marjorie, go ahead. Go ahead.
Present day to everyone.
Yeah, go ahead.
Thank you for watching this live webinar today. So can I share my screen?
Yes po, go ahead po.
Okay, so today, let me start by saying that emergency medicine is a very dynamic specialty. So that's where we are in. We cater a large variety of medical cases from day to day. So who needs to be treated first? So let me start by saying that the number of patients rushing to the ED can go as 180 or 200. Per day. So how do we handle these patients going to ED all at once? Patients consult in the ED starts with what we call the triage. That's the first line. So my topic for today is all about triaging patients. So who needs to be treated first? So here we have here some pictures in where it depicts like funny pictures where how they perceive people going in the triage. So it's important for the patients and also the physician who is seeing the patients to sort which one will go first. So let's start by having some definition. So triage is derived from the French word trier. This means to sort. So it's used to be a description of sorting agricultural products in France. So the practice of triage in the medical field, they arose from exigencies of war and remains closely related to military medicine. Triaging is sorting of patients for treatment in situation at least modest resource scarcity. So there is a resource that we need. And according to an assessment of the patient's medical condition and application of established sorting system or plan. So the common types of triage that we have are inpatient triage, and the second is incident, or we call it the multi-casualty triage, and disaster or mass casualty triage, and the most common, very familiar to us, is the ED triage. So we first define and what is inpatient triage is. So the very common here is the ICU. So in the more common situation of relative scarcity of at least some hospital-based resources, decisions must be made about who will receive priority access to those services. If these decisions are based on assessment of the patient's condition and are more according to some system or plan, they are triage decisions. The most common inpatient triage decisions involve access to intensive care. So for those critical patients, so who are needing ICU beds, so they are need to be triaged. So because they are needing resources. So these decisions allocate ICU beds to those who can most benefit from this level of treatment. So in countries who are less affluent, limited hospital services, inpatient triage decisions, they are routinely done. So, so as to prioritize access to surgery and diagnostic imaging, as well as intensive care. So that's for the inpatient. So the next type is the incident or multi-casualty triage. This is also very common. So this type of triage is designed to respond to an incident that creates multiple casualties, as for example, a multiple motor vehicle crash, major residential fire, or a commercial airliner crash. So these events place significant stress, but typically do not overwhelm a local emergency system. So for that one, we need also to sort patients. So additional physicians and other medical support may be needed to help to treat the large number of patients that are coming and with urgent needs. So the next is the military or battlefield triage. From my introduction, the triage or trier, it's from the sorting. So they started in military medicine. So triage officers and treating professionals, they are typically members of the military service. And patients usually are also military personnel. So triage officers and treating professionals, they are members of the military service. Accomplishing a strategic or military mission may influence military systems. So with that, they have obligations, allegiances, and expectations not shared by other healthcare professionals or general public. So a law and international law, such as the Geneva Convention, define legitimate and illegitimate practices when different categories of wounded soldiers and civilians are treated. So the next is disaster or mass casualty triage. So let me define the medical disaster. It occurs when the destructive effects of natural or man-made forces overwhelm the ability of a given area or community to meet the demand for healthcare. So the triage system that are used, examples are MASS or MAS. So it's an acronym for Move, Assess, Sort, and Send. SALT, Sort, Assess, Life-Saving Interventions, Treatment, and Transport. START, Simple Triage and Rapid Treatment. And Jumpstart. It's also a start, but used in pediatric patients. So for the medical rescue chain, this one is used in the mass casualty. So here it started with the disaster area and will end in the hospitalization by the patients are being provided urgent care. So there are 4 series of triage being done here. So the first in the disaster area, and then in the advanced medical post, and then the third triage during transport, and the fourth triage in the ER or ED triage. So one of the triage systems that we use in mass casualty, the very common is we call START, or this is simple triage and rapid transport. It is currently the most widely used triage system for mass casualty incidents. It is developed in 1983 by the Hoag Hospital and Newport Beach Fire Department in California. These are for rescuers with basic first aid skills. So the injured victims are designated by using 4 main categories main on injury severity. So black for the disease or expectant, the red for severe injuries but with high potential for survival, the yellow, delayed, these are the serious injuries but not immediately life-threatening, and green, or what we call the walking wounded, these are minor injuries. So this is a color-coded triage where triage colors may be assigned by giving triage tags to patients. So green patients are assigned by asking all victims who can walk to a designated area. So all non-ambulatory patients are then assessed. Black tags are assigned to victims who are not breathing even after attempts to open the airway. So the red tags are assigned to any victim with any of the following: respiratory rate more than 30, absent radial pulse or capillary refill time more than 2 seconds, and those unable to follow simple commands. Yellow tags are then assigned to all others. So with that, let's have a case scenario. So a woman runs up to you supporting her left arm and says, "I think it's broken." The respiratory rate is 24 breaths per minute and the pulse rate is 120 beats per minute. So how would you label her? So you can type in your answers. So
Let's use the chat. Use the chat. So lagay nyo yung everybody. What do you think? How would you classify? Yan na. Okay. Okay.
So the answer in that scenario is green. So it's a minor. What makes it green? So first we ask the patient who are walking. So the patient is walking, who runs up to you. So that patient is excluded already. So the patient is triaged as green, or the walking wounded. So let's have another case. So the next case is a man you approach a man who is lying on the ground. He is having 36 breaths per minute. There is no radial pulse. The capillary refill time is more than 2 seconds. It's 5. And he moans when you use a painful pinch. So how would you label this patient or victim? So
Yan, Marjorie, dami nilang sagot. Oh, they're answering.
okay. So the correct answer is red. So the answer is red. The patient is lying on the ground, makes him not in the green for walking wounded. his respirations is over 30 breaths per minute, the radial pulse is absent, and capillary refill is more than 2 seconds. And the patient is moaning, so does not follow commands. So we tag the patient as red. So that's the 2 case scenarios. So we're done with the mass casualty triage. We proceed with ED triage. So the last type of triage, which is the most common, is the ED triage. That is the one we are seeing in the emergency department. So the triage officers, usually nurses, are experienced ones. They routinely assess all the patients who present for treatment to sort and prioritize them. So we have a system in doing triaging. So these ED triage systems are typically designed to identify the most urgent or potentially most serious cases to ensure that they receive priority treatment, followed by the less urgent cases on the first come first served basis. So in routine ED, triage resources are available to treat every patient, although those who are less severely ill or injured must wait longer. Some patients choose to leave the ED rather than continue waiting for treatment. Some ED triage systems are designed to identify patients with very minor problems and refer them for treatment at clinics or by their own physicians. So the ED triage system has an associated time required for assessment in each level. So the ED triage system we have are 2-level system in which we categorize patient as emergent and non-urgent. 3-level system, we categorize the patient as emergent, 2 for urgent, and 3 for non-urgent. A 4-level system in which we categorize the patient as life-threatening, 2 for emergent, 3 for non-urgent, and 4 for urgent, for non-urgent. And 5-level system, there are a lot of 5-level system based on the countries in where they originate from. So the one we are using is the ESI, or the Emergency Severity Index. And we have also the CTAS, the CTAS, and the ATS, the Oscillation Triage Scale. The United Kingdom, they have also their triage system called the Manchester Triage System, or MTS. They use 52 algorithms based on the chief complaint of the patient. So let's discuss the Emergency Severity Index, or ESI. This is the one we are using in our emergency department. It is a 5-level triage developed in the United States. It designates the most acutely ill patients as level 1, the highest level, or 2, and uses the number of resources a patient needs to determine levels 3 to 5, 5 being the lowest. Here are the resources that we are talking about for 3 to 5. So the resources are that the patient needs can be laboratory such as blood and urine, and diagnostics such as ECG, X-ray, CT, MRI, ultrasound, or angiography. IV fluids for hydration, IV or IM or nebulized medications, patients who are needing specialty consultation, patients who have simple procedure such as laceration repair or polycatheter insertion. If the procedure is complex, we count it as 2. What are the things that are not we count as resources? Not resources are history and physical examination, point of care testing, saline or HEPLOC, per oral medications, tetanus immunization, prescription refills, phone call to primary care physician, dressing of wound, or rechecking if the wound is healing in those patients with crutches, splints, and slings. So this is important because we must also take note that we count the different types of resources, not as individual tests or X-ray. So for example, CBC, electrolytes, and coagulation profile is just equivalent to one resource. So if you need complete blood count or CBC plus chest X-ray, that is already equals to two resources. So we don't count it based on the same type of laboratories. So we count it as a different type of resources. So this is the algorithm for emergency severity index. So we start with as if this requires an immediate life-saving intervention. So we categorize that one as ESI 1 or level 1. So we check here if the patient needs immediate life-saving interventions or simply is the patient dying. We evaluate the ABCD or the airway patency, breathing, circulation, and disability. As we can see, these patients are pulseless, apneic, in severe respiratory distress. Their saturation is below 90%, in acute mental status changes or unresponsive. So this patient needs immediate physician involvement in the care of the patient. And this is very critical. This is one of the differences when you designate the patient as level 2. So if the patient is not dying or doesn't need an immediate intervention, we categorize the patient as level 2. But these patients are in the high-risk situation. So what are the high-risk situations? The patient is confused, lethargic, or disoriented, in severe pain or in distress, one who could easily deteriorate, and one who could have threat to life, limb, or organ. So we decide if this patient should wait or not. So for level 3, so when the answer is no, so we proceed to the next level. From level 3 to 5, we determine the level by counting the number of resource that this victim or patient needs. So in level 3, the patient needs many resources. That these resources are needed for the physician to provide adequate care and to allow the physician to reach a decision. The decision, this position is it's whether to admit or discharge the patient. So if many resources are needed, we evaluate again the patient. So if the patient has unstable vital signs, we designate the patient as level 2. But if there is no problem with the vital signs, we categorize the patient as level 3. So for level 4, this patient needs one hospital resource. What are the examples? Examples are a 35-year-old female who is healthy, having urinary tract infection but denies vaginal discharge. And a healthy 10-year-old boy with a minor thumb laceration. This one is just using a simple procedures, or it can be just addressing. So it's just one resource. For level 5, the patient does not need any hospital resource. So an example of this is a 43-year-old male with cold and a healthy 57-year-old female who ran out of her BP medicine yesterday. So the patient just needs prescription. So prescription is not counted as a resource. So they are categorized as ESI 5 or level 5. So we have cases here. So this is a case scenario of a paramedic who arrived with a 42-year-old morbidly obese female. So with a chief complaint of shortness of breath. On arrival, the paramedics found that the patient is breathing is labored with a tachypnic respiratory rate and the saturated oxygen at 84%. And the other history is not unable to obtain. So what is the emergency severity index category of this patient? So this patient's category is ESI 1. Due to this patient's needs life-saving intervention. So we categorize this as 1. So for another case, so this patient, she told you that she thinks that she has a urinary tract infection. She's 19 years old, and these symptoms has been for 24 hours already. The symptoms are fever, chills, or vaginal discharge. She has no other complaints aside from that, and the patient is healthy. So again, we go to the algorithm. Is this patient having needs a life-saving intervention? So it's a no. So is this patient in a high risk situation? The vital signs and the ABCD are okay. It's normal. So we proceed with level 3, 4, 5. So how many resource does this patient needs? So for this one, the patient just need one resource, maybe a urinalysis. So it's counted as 1. So it's categorized as ESI 4. So for our last case scenario, so a 33-year-old female who presents to the triage from ophthalmology clinic and complains a severe 10/10 frontal headache. And she thought that she needs eyeglasses. But the ophthalmologist referred her to the ED for further assessment because of her blood pressure that is 260/160. So we again go to our ESI algorithm. Does the patient need in a life-threatening condition that needs intervention? So the answer is no, that immediately. Is the patient in a high-risk situation? So the patient is having a severe frontal headache that is 10/10. So that is a high-risk situation. So we categorize the patient as ESI 2. So the patient is in severe pain, and also the blood pressure is 260/160. So the patient is categorized as ESI 2. So in summary, so we discussed triage definition, the most common types of triage. We focus on the mass casualty triage using the START system. And in the ED, we are using the emergency severity index. And we also cite some case scenarios where we use the START and ESI. So that's the end for my presentation. And I would like to invite everyone also, this is just plugging, for our international event happening this April 28 to 30, 2023, in SMX Clark Convention Center, Clark Freeport, Angeles City, Philippines, the ASEM 2023, our 12th Asian Conference on Emergency Medicine. And the Philippines will be hosting this event. I hope you could register and come. You can scan the QR code or visit our website. And these are my references. And to end my presentation, it's my pleasure to share our 25th year anniversary video clip, so we can share with you some clips with our event last December. Thank you for listening, and hope you learned something from my presentation. Thank you.
Okay, thank you very much, Doc Marge. Is there a video that you're going to show?
I would like to thank God for His faithfulness, for His mercy, His grace, His blessing to the department throughout the years. I really believe in my heart that we will not reach this far without God's guidance.
We got a beautiful story. Every moment on and on. We got a beautiful story.
Thank you, maraming salamat sa inyo. And mabuhay ang Department of Emergency Medicine. I hope to see you kahit in a wheelchair in another 25 years. I want you to stay as silver as you can to all the graduates, the young emergency physicians. Show them your brilliance wherever you will go. Show them your leadership wherever you will go. Show them that you were trained at the Philippine General Hospital, Department of Emergency Medicine.
Wow! Palakpakan naman dyan. Thank you so much. My goodness, congratulations, Doc Marge and Ted. Congratulations. We'll hear from you later. I really appreciated the presentation, Marge. I think the audience also did. They were all very, very engaged, and everybody was thinking with you. So, you know, I think this is really a very interesting presentation. We've not had this kind of a presentation before, and I think this also refreshes everybody's memory on, you know, how do we handle emergency situations. So thank you so much, Marge. Okay, over to you, Raymond.
Thank you, Dr. Susie. And thank you, Dr. Marge, for your presentation, trying to understand how emergency medicine developed, and most especially yung section po on process flow of the Department of Emergency Medicine. But I really like best the engagement with the audience. Yun po. We don't have that so much. So we really appreciated that po for in your presentation. Okay, before I introduce the next presenter, just wanted to remind everyone, kasi I haven't seen any questions in the Q&A, please feel free to type in your questions po. No? We will be choosing questions from the upvoted questions to be asked to our panelists. Hope you can start typing in your questions in the Zoom Q&A, as well as if you're outside of the Zoom, in the comment section of Stop COVID Deaths or the TVUP Facebook pages or TVUP YouTube channel po. Okay, it's our pleasure to introduce our next presenter, another new face to the webinar, an emergency medicine specialist at the Philippine General Hospital. Please welcome to your screens, Dr. Christopher Manalo. Dr. Manalo.
Thank you, sir.
Go ahead, Dr. Go ahead.
I seem to cannot share my screen.
Okay.
Oh, there.
Can you do it now? There we go. There we go.
I think you need to go to presentation, no?
Okay.
I think this is it, Dr. Susie.
Huh?
It's already visible. All right. Good afternoon. Good afternoon, everyone. Thank you for having us here today. I am Dr. Christopher Manalo, and in this part of our webinar, I will be presenting protocol-based management and the team approach in emergency care. My objectives for this afternoon are to introduce the emergency department and its institutional function, to introduce the team approach in rendering emergency care, and to introduce clinical pathways, their significance, and impact in terms of patient outcomes. So let us first define what an emergency department is. The Philippine General Hospital Emergency Department is under the central administration of the Department of Emergency Medicine and is a unit for the care of emergency cases, providing initial phase of acute and emergency care operationalized by emergency physicians, residents in training, multi-specialty physicians, nurses, paramedical, and administrative support staff. In the emergency department, we manage and treat injured and acutely ill patients with life-threatening conditions. The ED is a facility where many different units, departments, and even institutions outside of the Philippine General Hospital are integrated and linked in terms of delivering acute and critical care services. The ED also maintains its records of all patients seeking emergency services. And most importantly, the ED and its manpower assure and maintain a mechanism for quality and improvement of care for all patients. As a university-based emergency facility, the Philippine General Hospital Emergency Department provides appropriate training, education, and medical research. And lastly, the Philippine General Hospital Emergency Department functions as a disaster center and functions to provide pre-hospital and management services. Teamwork in healthcare is particularly important in the dynamic domains of emergency medicine, critical care, resuscitation, surgery, and trauma. Within and across these services, the emergency department teams led by an emergency physician must be coordinated to provide optimal care in order to achieve desirable patient outcomes. Teamwork in the emergency department will further be emphasized as we discuss clinical pathways, its significance, and impact in patient outcomes. Clinical pathways have been used in healthcare settings since the 1980s and are widely utilized in the United States, Canada, Europe, and Asia. Clinical pathways improve cost effectiveness and reduce length of stay by up to 22%. Most importantly, clinical pathways reduce substantial variation in patient care. Clinical pathways established through evidence-based medicine can significantly decrease clinical practice variability, thereby reducing overutilization of resources. Likewise, clinical pathways can identify systems issues that interfere with effective patient care and facilitate resolution of systems problems which can be inconvenient to both clinicians and the patients. In the Philippine General Hospital, Department of Emergency Medicine, we have a number of clinical pathways implemented in the emergency department. Some of these clinical pathways are code STEMI for myocardial infarction, the sepsis pathway for life-threatening infection, and the brain attack protocol for hyperacute stroke. These clinical pathways were conceptualized and operationalized through science of many different medical and surgical specialties. As these pathways are activated, a multi-specialty team of physicians come in and manage the patient together with the physicians and trainees in emergency medicine. A clinical pathway I intend to further discuss is the acute behavioral change pathway with code gray integration. I see this pathway as a representative pathway that fosters a close team approach and dynamics. This pathway is activated for patients 19 years old and above with acute behavioral change of undifferentiated etiology. May it be medical, neurologic, toxicologic, psychiatric, or a combination of any of these etiologies. Upon the activation of the acute behavioral change pathway, it is imperative that we determine our safety and or if there is any security issues. Any sign of danger shall warrant activation of Code Gray, thus integrating the University of the Philippines Manila Police. The purpose of Code Gray is to provide an appropriate response to situations involving an aggressive, hostile, combative, or potentially combative person. An aggressive combative, or abusive behavior can be displayed by anyone, a patient's family member or acquaintances, even employees and outsiders. Aggressive, combative, or abusive behavior can even escalate to a more violent episode we call cold silver. Cold silver is activated when an aggressive person is now actually armed with firearms such as guns. For the emergency department management, for any patients with acute behavioral change, we first do verbal de-escalation. We try to talk to the patient. We try to know what they feel. We try to know what their demands are in order to de-escalate the agitation that they feel. Second line in the management would be to subdue, neutralize, and do temporary restraint if verbal de-escalation did not do benefit. During neutralization and temporary restraint, we actually require 5 able-bodied persons, 1 for each extremity and 1 on the head. The 5 able-bodied person would exclude the nurse who will administer the medication, and of course, the physician who will initiate care, stabilize the patient, and work up in order to definitively know what's happening to our patient. This photo shows how a scenario of neutralization is done. However, the mistake in this photo is smothering the patient's mouth. So I recommend that during whenever we subdue or whenever we neutralize a patient, we use a non-rebreather mask with delivery of high flow oxygen in order to cover the patient's mouth and nose. Delivering oxygen could also be therapeutic for the patients because sometimes hypoxia or low oxygen in the blood could cause agitation. And lastly, or for the third line of TB management, we do sedation and rapid tranquilization. A systematic review and meta-analysis on rapid tranquilization and of an agitated patient in the emergency department studied different pharmacologic agents, their effectiveness and safety in terms of achieving adequate sedation. So in this study, it was found out that ketamine showed the highest effectiveness in sedating patients within 30 minutes. However, in terms of outcome, the study found that droperidol in combination with midazolam are the safest option for sedation in less than 30 minutes. Serious adverse events noted during tranquilization would be cardiac arrest, ventricular tachydysrhythmia, endotracheal intubation, laryngospasm, hypoxemia, and hypotension. After we have subdued and neutralized our agitated patient, we ensure hemodynamic stability. So we address the patient's airway, breathing, circulation, disability, and exposure. And following that would be the recognition of crucial problems and the potential etiology and subsequent management. At this point, further team-based management would come into play. We do referrals for co-managing services to general medicine, neurology, toxicology, and psychiatry. Just like I mentioned before, the cause of agitation could be secondary to a general medical condition, to a neurologic insult, something substance induced like alcohol, methamphetamine, or other illicit drugs, and psychiatric conditions such as schizophrenia. So to end my lecture, some takeaways would be that the emergency department is a service unit for the care of emergency cases, providing initial phase of acute and emergency care operationalized by emergency physicians, multi-specialty physicians, nursing, paramedical, and administrative support staff, fostering a team approach for optimal healthcare delivery. And if we would appeal, the emergency department should be reserved to life-threatening conditions. Clinical pathways are also utilized for quality assurance and process improvement, which is a key element in healthcare setting, constantly working to improve effectiveness, efficiency, and safety. And lastly, the acute behavioral change pathway with code grade integration is an excellent example of a clinical pathway integrating a multidisciplinary team approach in the emergency department. This ends my lecture, and thank you very much.
Thank you so much, Dr. Fer. Very succinct, but also just trying to understand how research has been converted into emergency protocol, involvement of frontliners during COVID-19 pandemic, in formulation of practice guidelines. So many things that I'm sure our audience will have questions po. No? So congratulations and thank you for your presentation. Dr. Susie?
Okay, thank you very much. Topher, I also loved your presentation. No? Parang very logical. So there's logic and evidence in emergency management. Wait, wala yung ilaw frame. I'm sorry. Okay, so last but not the least, okay, we have with us one of your favorites who's what should I say? I mentioned this earlier that he started the emergency department in its new form 25 years ago, and now he's back and looking and reaping the fruits of what he planted. You also know that he was responsible for putting Stop COVID Deaths on the air. So what else can I say? But let's welcome Ted HERBOSA. Ted, welcome.
Thank you, Susie, and thank you, Raymond, and to all the peacekeepers. No? I'm really proud of my graduates in emergency medicine. Let me start by beginning with a reaction about how these people helped us during the time of COVID. I was there at the National Task Force advising the chief implementer, but though all the emergency physicians never left their post, they worked long hours. Some of them died, some of them really got sick, and they continued to serve. They served to their mandate. Ang usual question to me is that, what is emergency medicine? No, to me, emergency medicine is just good medicine, and that's what I teach them. If you're doing right, you're probably going to take care of the patient. And that goes to the second principle of what emergency medicine is. Emergency medicine is about patient advocacy. If you heard the man on the street talk about how they were treated in an emergency department, I would honestly say that those people probably went to an ED without an emergency physician. Why? Because that was the way Susie and I were educated. When the time we were interns, Susie and I, it was the security guard who will ask the patient, what's your problem? And then based on their answer, he will decide whether he will send you to surgery ER, to medicine ER, to otorhinolaryngology ER, or to OB ER. So a lot of the time, the triage was wrong and people were passed on like basketball from one court to the other. So I wasn't happy with that after my fellowship training. So I decided there must be a better way. So I met one of the authors of emergency medicine in the US, Dr. Peter Rosen, and he told me there is no other way to run an emergency department, a modern emergency department, than without emergency physicians. So sadly, in the Philippines, after 25 years, we still have majority of emergency departments not being run by emergency medicine specialists. They're usually moonlighters, people who want to earn money. They're hired by hospitals. They make them staff the ED, private hospitals. Even in other hospitals, if they don't have an emergency medicine, those that will be asked to staff the ED are residents in training of surgery, opta, internal medicine. So if you're in the ED and it happens that the one on duty is a surgeon, so better not be an acute myocardial infarction, because he can't operate on you. And if you're on duty, if the doctor on duty is an IM, and what comes in is trauma, you're also lucky. You're also going to be unlucky because he's gonna not be able to take out the bullet if you've been shot. So this is the concept of why we need the emergency physician. The emergency physician is like the Marines in the. They're like the Marines in the military sense, wherein they're in the front lines. And when I talk about the health system, I like to look at the emergency physicians as the bridge between community or the public health and the hospital side. So we bridge. Many of the early graduates of emergency medicine took up masters in public health because they saw that the ED was just a recipient of society's bad behavior. So all the gaps in the healthcare system actually manifest in an ED. If your ED is full of ambulatory ES4 or 5, there is something wrong with your outpatient clinic. That means they cannot access primary health care. So they're using the ED as their primary health care, which burdens the other people that require emergency care. So these are the nice things we've learned over the 25 years that I've been teaching emergency medicine to young doctors. I'm also very happy that many of my graduates started similar programs in all the government hospitals. So I'm very proud that the PGH graduates are in almost all DOH big hospitals and have started programs again in emergency medicine. But let me go back and react to the first speaker. Marge talked about the importance of triage. You see, one of the first principles of emergency medicine is to prioritize need. You also heard that from the man on the street. The lady was saying, sana wag nang tanungin yung edad ko or yung what other data. Unfortunately, we can't get away from that, but we want to find out through certain techniques, whether it's the respiration, perfusion, mental status, or the ESI severity index. What we can do is actually be able to scientifically prioritize patients that we will see initially or we will not wait long. So mabawasan yung waiting time. So she emphasized the fact that there is what we call effect-related care. So why will you admit a patient to the ICU if there's only one remaining ICU bed and the patient will die anyway because it's a poor prognosis? If there are 2 or 3 other patients with the good prognosis and requires an ICU bed, then I will put that patient there. So that's ICU triage, and that's called effect-related care. So over the years, I've learned to teach my young residents that the way to practice emergency medicine is to be able to identify 2 things. First, you need to identify the immediately life-threatening conditions, things wherein the patient can die, and act without being able to get a good history and PE, which they teach us. So this is called the primary survey approach. When we do an ES1, ES2 patient, we actually do what is called the primary survey or the search for life-threatening conditions in the airway, breathing, circulation, neurologic deficits, and the other parts of the body. So that's the ABCDE approach. So that's very important because before you go there, after the primary survey, follows the secondary survey. The secondary survey is all about searching for potentially life-threatening conditions. Conditions wherein the patient may die. And we're not like IM. IM will try to look and find out what the patient is sick of. Our goal is not diagnosis. Our goal is to make sure that the patient in the ED is passed on to the IM person, to the internal medicine, if the problem is a diagnostic problem. If the patient is a surgical problem, then that patient must be referred to a surgeon or must get the surgical procedure ASAP or as the fastest. So yun yung dalawang tinuturo ko. If you're in the ED, you look for immediately life-threatening conditions and correct it. You don't have to wait for the actual diagnosis, but you can correct airway by intubating. You can correct bleeding by giving volume and fluids and blood. And also you can stop bleeding if there is external bleeding. And then you have to identify if they require a surgical procedure, an emergency surgical procedure. For the rest of the procedures, it's also very important that we are also the lifeblood of the hospital when it comes to mass casualties, disasters. You see, we've extended our work outside the ED in the pre-hospital setting. So field triage, mass gathering events. We're also the ones covering, let's say, the San Nazareno in Quiapo. We always cover that because of the many that are injured, or even political, or even concerts wherein we are able to provide physicians on site. Even sporting events, part of the coverage of emergency medicine is being able to do that. On the other hand, see Topher, who's also the one who's a co-chair of our research committee, emphasized the need for team approach. Before we called the ED an emergency room because there was only one physician and there was only one room and probably one or two nurses. But today, there is no more ER. There is an emergency department. It's a whole department, and it's got a team of emergency physicians, trauma surgeons, interventional cardiologists, stroke specialists, poison experts, and all of us combine to form teams that go into critical pathways. I'm very happy to announce that we're up at the PGH. We've now equipped, through the work of Dr. Gap, we've now equipped the ED to almost par level with any first world country. But what we are not yet par level with is our process of being able to do the team approach. So we still need to improve our STEMI protocol, our brain attack protocol, and our trauma protocol, and all other protocols that we're developing one by one. But we need a certain level of team approach. And the silo thinking in the hospital prevents me from doing that because other departments continue to look at their own stakehold in terms of what they want to achieve and not try to work for a team. So I'm glad that was actually emphasized. We can only achieve the goal if it's like teamwork. So in fact, my colleague and boss at the University Kabangsaan, Malaysia, where I worked for 3 years, also training emergency physicians there, kind of alluded it to football because they're all addicts of the English football. He alluded it to the fact that there is a goal to save the patient's life, but the emergency department is like the football team. There is a forward, there is a goalie, there is a midfielder, and there is a backfielder. So everyone has a specific role, and the better success is achieved when people actually perform well in all their roles. I think I will end there, no? And I think I'd like to congratulate our emergency physicians, but I'd like also to thank TVUP for focusing on emergency medicine. We are not trying to give an excuse. Our emergency departments are busy. I think part of the problem is not the emergency department, but it's our health system. We have our bed to population ratio continues to be low, and our government hospitals now receive 80% of the brunt of emergency cases because the private hospitals are too expensive. So we're giving away free care at the emergency department, but in the process, we are lowering quality because we are overburdened with ED overcrowding, access blocks to actual available beds in the hospital. And we have, if you visit the ED in the PGH, we have all the equipment you need for a first world ED, but we have overcrowded it with patients that are poor and can't be admitted in other hospitals. So with that, thank you to TVUP for covering emergency medicine. I do hope people learned a lot about emergency. I don't want to meet you in the emergency department. Anyone who's watching, please take care of your health. In fact, sabi ko nga kanina in the start, the ED is the recipient of society's bad behavior. Don't drink and drive. Don't do drugs. Behave well, drive safely, and you won't be in our emergency department. Thank you, Susie. Back to you.
Thank you so much, Ted. Really, I'm blown away by that, by the wisdom, no? Parang after looking at this full circle, you did 360-degree here, Ted. You started it, now you're training the next generation. And in the video clip, you said, even if I'm in a wheelchair in the next 25 years, I want to be here. I think, this is a testament to yung sinasabi natin, yung galing, yung husay ng mga Pilipino eh. We don't, we always criticize ourselves, but actually there are some amazing things that have happened, and I think we're just witnessing one of those through this webinar. So thank you so much, and please stay for our Q&A. You'll see all the thank yous in the chat box, and the emoticons that were going on while you were talking. Okay, so Raymond, over to you.
Okay, thank you so much, Dr. Susie, and thank you also to Dr. Ted Herbosa for your comments po, and for your reactions, and trying to spearhead all of the work that's being done at the emergency medicine department po, no? At this point, we'll ask our panel to switch on your video so we can begin our Q&A session. And while the panel is switching their videos po, we'll take a very quick break for a special public service announcement today.
O sige na, anak. Parang kagat lang ng langgam. Kantik o yung kumikiliti lang? Ito naman parang hindi ka pa nababakunahan dati. Akala ko pa naman brave girl ka. Nakakahiya na kay Doc.
Okay lang po, nanay. Ay, ang cute naman ng shirt mo. Favorite color ko rin yan.
Doc, favorite ka rin po ang color nito. Pero ayoko po ng red hunting. Masakit kumagat at takot rin po ako sa blood. Magtudugo po ba ako sa bakuna?
Ah, hindi. Walang dugo sa bakuna. Konting pisil lang, tapos na.
Kakasugat ba ako, Doc?
Hindi ka magkakasugat. Lalagyan lang natin ng plaster pagkatapos para safe. Di ba nabakunahan ka na rin ng contra measles at chickenpox dati? Parang ganun lang din ang bakuna para sa COVID-19.
Natatakot pa rin ako, Doc.
Alam mo ang secret sa pagiging brave. Hindi ibig sabihin na wala kang kinatatakutan. Kundi, kahit natatakot ka, hinaharap mo pa rin ito.
Okay. Ready na po ako, Doc.
Una, pupunasan ko muna ng bulak na may alkohol ang braso mo. Okay? Tapos, mabilis lang na konting... Ayos! Tapos!
Tapos na, anak. Pwede mo nang buksan ang mga mata mo.
Nay, sabi sa inyo, brave girl na po ako eh.
O, heto ang prize para sa'yo, ha? Wow! Bagay sa shirt mo. That's the color of bravery.
Color rin yan for love.
Thank you, Doc. Thank you, Nay.
Dahil ako po ay mahal ninyo, nagpabakuna na ako.
Mga bata, magpabakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Okay, thank you so much, TVUP. The COVID Communication Public Service Announcement is one of the many creative outputs of the Stop COVID team to push for pediatric vaccination for children age 5 and above. Please share this video clip with all of your social media accounts po. Stay safe and stay well. Magpasama na sa Bakuna Center. Dr. Susie?
Okay, thanks. So we've got all our speakers, and I just wanted to sort of get the ball rolling here. I have a question for Ted and then a question for Marge and Topher. So, and I'm going to ask Marge and Topher to think about their answer while I'm asking Ted the question, right? So the question is, why did you go into emergency medicine? So think about it, because I'm going to ask you. Oh, Ted, I think the question is, so I was really struck by what you said, that you can't have an emergency department without emergency physicians. So when you are looking for
I didn't say that.
doctors,
Dr. Peter Rosen said that.
Yeah, but you shared it. Yeah.
Author, yeah.
I'm struck by that, right? It's not about the technology. It's not about the building. It's about the people, right? So, okay, so I know there are a lot of young people who watch Stop COVID Deaths. We have many medical students who actually watch this. So my question is this, like, when you're looking for talent, you're looking for, I'm sure you kind of informally recruit, right? People to come into this field. What are you looking for?
The type of person that would thrive in an emergency department are what I call hyperactive adults. These are people who can see 2, 3, 4, 10 patients at a single time and become elated by seeing more patients. They're the ones who don't like to say walang pasyente or I'm just sitting around waiting in the hospital. They're the type of people who are what we call obsessive compulsive behavior. They are hyperactive. Anong tawag doon sa children? ADDS.
ADHD. May ADHD.
ADHD pero adult. So they're the type of people that I think work out. They are also very humanitarian. These people, you want to become a brain surgeon. You also think about the remuneration you get out of being a cardiac surgeon, a neurosurgeon, or a cancer surgeon. But the type of people that go into the ED are very humanitarian. In fact, if I call my residents and I want to do a surgical mission in the mountains in Morong, I will have 10 volunteers immediately. That's the type of people I have. So I look at that and I see the people that quit are those that can't handle that. So they work hard, but they also play hard. So in my batch, there are people, in my graduates, there are people who are mountain climbers. There are people who are, weird sports. There are people that go to oil rigs. They go on ships, on cruise ships to do adventure. It's like being a doctor without being a doctor, because the other specialists, they have to worry. An OB-GYN has to worry about a patient that's about to go on labor and deliver and will miss events of their children. An emergency physician will not do that because he can schedule his life based on duties. You're on or you're off. So you either take on duty or you're off. You want to make more money, you go on duty every day. You'll make more money. But not many people do that. They end up having a life-work balance. So for the youth, the younger generation that looks for life-work balance, emergency medicine is actually that field. You're able to go on 12-hour shifts, take out, and you're not worried about the patients you treated because someone else is going to take care of them.
Oh, thank you, Ted.
For the new generation.
Oo. Tsaka parang I remember that movie Divergent, no, yung mga Dauntless.
Yes,
diba?
yes, Dauntless.
Those who, they're very brave or courageous. So I really appreciate that. Okay, so let's ask Topher first. Topher, put your camera on. Why did you go into this specialty?
Well, emergency medicine was really my first choice back in medical school and internship. I chose emergency medicine primarily because I really want to treat patients, see patients, and be with them during the most critical times of their illness. And it gives me that joy to see them recover, though some patients would really die under my care, but seeing them recover, giving my my most urgent and compassionate care, it would be most rewarding for me.
Oh, thank you so much, Topher. Marge, ikaw?
Ako po, emergency medicine kasi po parang sa mga emergency cases, parang feel ko na doktor talaga ako. Kasi kapag merong lumapit sa'yo, at tapos, kasi naisip ko kung ibang specialty ang kukunin ko, pag may lumapit sa akin, hindi ko mapoprovide yung care na kailangan in any situation. So that's number one. And number two, it takes a personality to be an emergency physician kasi it's very prone to burnout kasi 'di ba even in a 12-hour or 24-hour shift and you will do that every day, it will burn you out. So you need to have some outlet. And then of course, yun nga yung ADHD. So dapat meron ka din siguro noon, right? Kasi ito yung kailangan lagi kami adrenaline rush dahil laging toxic eh. So kailangan mong mag-adjust. Ang emergency medicine, sabi ko nga kanina, is very dynamic. So it can be from benign to being very toxic. And of course, there's more to being a doctor. Meron ka ring iba pang part of your life, social life, and also I choose emergency medicine because I can also have that aspect. So I can be a doctor, I can also be a daughter to my mother, I can be a sister to my siblings, and I can be a friend to my friends, and a family member to my relatives. So pwede ko siyang ma-schedule in a way that I wanted. So yun po siya.
Thank you very much,
Thank you
Marge.
po.
Okay, we're gonna go to Raymond. Raymond, let's pick up some questions from the audience.
I'd like to ask this question, but it's more, it has been answered by Dr. Marge, but I think many will benefit from this one. Coming from Dave Gamboa, in the triage scenario, how do you deal with relatives who will challenge your triage classification? Say you classify as low tier like ESI 4, but it's a higher tier in their mind. Dr. Marge.
As I've answered in the chat box, Sir Dave Gamboa. So it will all boils down to how you communicate with the patient, and how you will relate to the patient, the situation. So I think it's better communication. Talk to the person in such a way they can understand you. So the patient can be managed and be seen, and will be properly taken care of. Hindi naman ibig sabihin na nasa ESI level 4 siya, hindi na mapro-provide sa kanya yung needed healthcare na kailangan niya. So, na-designate lang siya as 4 because isa lang yung resource na kailangan niya doon sa hospital. But, na-provide naman yung kailangan niya kasi yun lang naman talaga yung kailangan niya. The patient doesn't need any other. Kasi kung in a private setting, na nagbabayad ang mga pasyente, and this patient is in ESI 4, and then ano ka sa kanya ng napakadaming mga laboratory exam, pina-x-ray mo yung patient, and yung sa healthcare system natin, mostly out of pocket yon. So, magkano yung magagastos ditong pasyente na to kung ilalagay mo siya dun sa maraming resource na kailangan niya, which is hindi naman siya para doon. So, itong classification na to ng ESI, makaka-benefit din to para dun sa mga patient economically. So, ito ang kailangan ding maintindihan ng mga pasyente din na pumupunta at nagpapatingin sa emergency. So, I think kailangan din ma-earn yung trust as a doctor para nang sa ganon, madali nilang ma-accept at maintindihan. Kasi minsan, kung walang tiwala sa'yo yung pasyente, syempre, magpapag-iisipan ka niya na mali yung decision making mo. So, kung na-explain mo naman sa kanya and then naipaliwanag ng mabuti, I think hindi siya magiging problem at all. Yan po.
I have a follow-up question for Ted, no? Using your classification, how does that work in terms of PhilHealth reimbursement?
PhilHealth doesn't follow this type of, and in fact, that's our appeal, no? That the Philippine College of Emergency Medicine start to reimburse all emergency consultations kasi walang reimbursement yun.
Sure. They should, diba?
Yeah. What happens, it's incorporated into the hospital bill if the patient is admitted. And if the patient is not admitted, after we save them, we don't get paid. So parang hindi right, di ba? So there's something wrong with our financial reimbursement for acute care. And I really think we should change this. I think we should reimburse pre-hospital care and emergency department care, whatever care.
Yeah.
Right now, ang binibigay lang is if na-admit yung patient, na-admit sa ICU, tapos kung minsan hindi pa kami nakaka-share kasi napupunta yon because it's so small, it just goes to internal medicine or to the surgeon, pero none goes back to the emergency department. So there's really something wrong with the financial reimbursement for acute care. The second is, ngayon, nare-reimburse pagka may surgical procedure. If you suture the patient, ganon. Yeah, so, sorry, iilig siya. Dati kasi board member ng PhilHealth si Susie. No, but there's still something wrong with that.
Ikaw din eh.
Kaya nga ako nag-resign, ano?
Resign ka na ba? Oh my goodness.
I think that's exactly what needs to be done. If there's anything in universal healthcare that needs to be paid for, hindi ba dapat primary care and acute care? Di ba
Of
yung
course.
dalawa ang dapat mo unahin?
Yeah.
So,
Yeah, at saka
ngayon,
doon mahihirapan.
nagkasabi ang PhilHealth, nag-announce ang PhilHealth, mag-increase daw sila ng bayad ng mga dialysis. Di mauubos
my
ang pera natin sa dialysis. And the people that need emergency care will still spend out of pocket. Parang may problema tayo doon. Diba? We talk about universal healthcare, but we're not reimbursing ED. Di ba? Kasi dapat ma-reimburse yung ED para gumanda. Or, the other way is improve the primary care para hindi sila pumupunta sa ED. Di ba? So both of those aspects need to be fixed. Sorry, mahabang usapan yan. That's another topic in itself.
Kala ko pa naman there was some progress in that space, no? But that's really so sad. That's so sad. Kasi yun talagang takot ng pangkaraniwan tao eh, di ba? Susugod mo sa ospital tapos wala kang pera. Tapos hindi ka marireimburse. So, why we define care as admission in a hospital, I still don't get that.
So we have the HMO side. So wala sa PhilHealth doesn't cover it. So if you have some money, you're employed, do try to get health maintenance organization or health insurance. Pero kailangan mo ng LOA pag pumunta ka ng ED. Someone has to approve na babayaran yun. So again, there are defects in the private system and there are also defects in the public system. But we need to fix that. That needs to be fixed.
Oh gosh. Okay, Raymond, pick up some more questions.
One more question, Dr. Susie, but we'll get it from Dr. Joseph Tortona, who is one of our regulars. Really, anybody who is trained to verbally de-escalate a situation when there is a gun-wielding person who enters hospital premises? Dr. Ted.
Well, guns are not allowed in the ED. That's why we have security guards in front of an ED. But of course, you know how security guards are. You know, they're not really trained to disarm anyone. So once you see firearms in the ED, it's a code. We call it a code because it can escalate and you don't want that. We've had doctors that have been shot in an ED. So actually may training. In fact, we're having one for our residents this coming Saturday ba? Kailan nga ba? We have about crisis negotiation and crisis management. It's all about communications. In the end, it's all about being able to communicate and making our patients understand that why they have to wait and why they can wait, and be able to tell them, even if that guy came later than you, we'll have to treat him because he's dying. So sometimes that requires, in a busy emergency department like PGH or any other government hospital, yun ang pagkukulang. Kung minsan wala nang time yung mga doctors to talk to them the way they do in, let's say, a private hospital where the doctor has enough time. So that's a risk, and we need to fix that as well. Thank you for that question, Joseph.
Yeah, I thought that was a great question. Kasi, yun nga, no? Of course, we see a lot of that on television, but yeah, that's a good question. Okay, so we are running out of time. I think, Raymond, let's answer the questions to the fun quiz.
Sige po. So we have 3 questions po, no? And I'll ask each of you a particular question for this one. For the first question, this will be for our first speaker, Dr. Marge. A patient comes in with difficulty in breathing, respiratory rate 30, O2 80%, heart rate at 40, with fever. Patient is classified as, Dr. Marge?
ESI1.
ESI1, okay. Sige po. And then for our question number 2.
Teka, pa-explain muna natin kay Marjon.
Go ahead. Why is it
ESI1, so this patient needs life-saving intervention. So that's the first question in the ESI triage system. So does the patient need life-saving intervention? So this patient needs life-saving intervention. So the respiratory rate is 30 with an oxygen saturation below 90%. And the patient is also bradycardic at 40. So we need to intervene or the patient might die. So that's SI1.
Okay.
Thank you, Dr. Marge. Next is for Dr. Topher. Question number 2. Patient comes in, motorcycle crash with protruding bone on the right leg, low blood pressure. Patient is classified as?
ESI1, sir. Because the patient is hypotensive and this could be a limb-threatening injury. So I'll classify the patient as ESI1.
ESI1, okay. Thank you, Dr. Topher. And lastly, for the chair of the Department of Emergency Medicine of PGH, for multiple casualty incident with dozens rush to the emergency department using color coding, how would you classify a patient? Unconscious but active bleeding and multiple fractures. Dr.
I'll
Ted?
classify them as red, no? Kasi sa start triage, we use RPM, respiration, perfusion, and mental status. So dahil mental status nito unconscious, red category na kaagad siya. By the way, madagdag ko lang dito sa triage, meron kaming tinatawag na reverse triage. And I used to teach this when I go to a mass casualty incident. I'll actually get the megaphone and say, I'm Dr. Ted HERBOSA. All of those of you are injured and wants to meet a doctor to see them, stand up and follow me. So all of those that follow me are classified as ambulatory kasi nakakalakad sila. And all the rest that are lying down and can't move are those that are classified as red or green category or yellow category. Thank you, thank you.
Okay, thank you so much. Thank you so much, Dr. Ted. We'll also go straight to our evaluation poll po, no, which is 5 questions. It's a 4-point Likert scale. And I hope our 3 speakers will take this time out to craft their last message po to our audience as we go through each of the questions. First question, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargon adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. We will not be closing our evaluation poll and we will not be sending out a separate one, no, by email. Ito na po iyon as we move on to the final messages of our speakers. Dr. Susie?
Yeah, thank you so much. Okay, we'll start with Ted. Ted, what's your message to our audience?
Yeah, my message to the audience is someone I heard on the man on the street or woman on the street. Sabi niya, nagpunta kami sa ED. Lahat ng mga doktor at nurse masusungit. Let me just explain that. No, I think I'm not going to give an excuse. They're not supposed to be masungit in the ED, but you should also understand that emergency physicians and emergency nurses are human beings. They get tired, they get burnt out. You don't know the consequences of that person being masungit. Maybe they just figured in a death. Maybe they just resuscitated someone and it wasn't a successful one. Or maybe they had an argument with a surgeon who didn't want to operate someone who clearly needed an operation. So let's be understanding, communicate, and let's not judge. Most emergency physicians have become emergency physicians because they want to save your lives. Thank you.
Nice. Thank you so much. Okay, Topher, over to you.
So final words. For me, the team approach to a patient in the emergency department is very important. Especially here in the Philippine General Hospital, most of our patients are multiply injured. They have many different health issues. They come in critical conditions. So as much as we want to render the best possible care as emergency physicians, of course, we would need the expertise of many different medical and surgical specialties. We have our counterparts in internal medicine, in surgery, both cutting and non-cutting services. And all of us, more brains to think, better patient outcomes. Thank you po.
Thank you so much, Topher. Well said. And let's go to Marge. Marge, go ahead.
So for my final message, so triaging is really essential. So the patients will benefit to the healthcare they will be needed. So the resources in both in the hospital setting and also with the patients outside. So this helps the people who will go to the emergency department, and they will save a lot of money in their economy if they will be triaged appropriately. And most importantly, they will get the healthcare needs that that is necessary for them.
Okay, thank you so much, Marge, and thank you to all our presenters and our guests today. It's really been very enlightening. And again, congratulations to the Philippine General Hospital Department of Emergency Medicine on your 25th on your 25th year. Wishing you all the best in the future. All right. We are going to have a closing remarks and a brief summary from someone you've seen on the webinar before. He's an ophthalmologist who was on the webinar as a presenter, but he's now going to give our closing remarks as advisor to the UP President for Academic Affairs and Research Development. So we'd like to welcome Dr. Leo CUBILLAN to give the closing remarks. Go ahead, Leo.
Yes, good afternoon everyone sa lahat ng nanonood dito. Thank you Doc Susie and Doc Raymond for the very interesting and relevant medical webinar focusing on the emergency medicine specialist. Sila yung mga frontliners natin, no? Being frontliners, kaya siguro they're featured in this multi-awarded Stop COVID webinar today. So thank you also to our emergency medicine specialist for sharing your knowledge and expertise with us today. Dr. Marge presented the different kinds of triage that is important to prioritize patient care. She mentioned that the color-coded medical rescue chain is activated during disaster. In PGH, we are using the Emergency Severity Index, which is a 5-level system based on the resources that the patients need. Kaya sinasabi nila na when you go there, hindi ka naman pipila because you will just be classified according to your needs. So ESI level 1, if the patient is dying, where you need multiple services. Level 5, when the patient does not need any hospital resource. Now, si Dr. Topher naman presented the team approach in emergency care for emergency medicine. Critical care sa resuscitation, surgery, and trauma. He also discussed the use of clinical pathways to reduce the length of stay by 22% and reduce the cost. In PGH, we have several of these clinical pathways. He mentioned the code STEMI for myocardial infarction. We have the sepsis pathway for life-threatening infection, the brain attack pathway for hyperacute stroke, and also they have the acute behavioral change pathway, where they have a code gray integration to contain agitated patients. So they use mask with oxygenation and rapid tranquilization. Now our Reactor, the founding and current chair of the PGH Emergency Department, Dr. Ted, he emphasized na the emergency medicine is good medicine, doing good medicine, and it is an advocacy for them. He said that our PGH Emergency Medicine Department is now equipped with facilities similar to that of the first world countries. And apparently this is like one of the few in the country, with emergency medicine. And he said that their department is the recipient of society's bad behavior. Kaya do not drink and drive. Although just in case, the PGH ED doctors are there to help you. Hindi sila susungit. I still remember actually when I was training in PGH. During my time, the triage system and emergency care, they're not as efficient and cost-effective as now, no? Ito ata yung time that Ted mentioned that sometimes the security guards are the one triaging. And so that's more than 25 years ago. So medyo nahalata yung age ko ngayon. But anyway, with the emergency specialists now in PGH Emergency Department, they play a critical role in providing timely and effective care to patients in critical condition. It is also inspiring to see that PGH, being a training institution, we developed the emergency medicine training program, and they can provide practitioners in other parts of the country with the skills and knowledge to support their communities. Also, in addition, the vital role of emergency medicine in disaster preparedness and response cannot be understated. It's really important. Lalo na we're expecting, what if there's like a major earthquake, and we always have typhoons. Other emergencies. On a lighter but important note, the popularity of emergency medicine infectional medical TV dramas like Grey's Anatomy. Nung time namin ER yun, no? ERs was popular. They have inspired many students to pursue career in medicine. This is important because as we expand PGH from UP Manila to other campuses, we now have a PGH in New Clark City, and soon we will have PGH in Diliman, and hopefully PGH in Mindanao. Actually, there is a global shortage of physicians, nurses, and healthcare professionals. And this is particularly felt in the Philippines, where the concentration of medical professionals is in the urban areas. However, the Philippine government's Universal Healthcare Program is an important step towards improving the access to healthcare services for all Filipinos. Through this program, we are hopeful that we can increase and improve our hospital services and provide quality healthcare to those who need it most. Now, the recent pandemic has brought the importance of healthcare to the forefront of our society and highlighted the need for a strong and resilient healthcare system. This is an opportune moment for our nation to restructure our healthcare system to ensure that it can meet the current and future healthcare needs of the Filipinos. Ang dream natin ay na pag pumunta ang isang pasyente sa ER, hindi niya poproblemahin na siya ay hindi matingnan or hindi siya makakabayad or magkakautang yung buong pamilya niya after that, no? Sana magkaroon tayo ng stronger healthcare system in the future. With that, thank you and good morning.
Thank you so much. That's Dr. Leo CUBILLAN, who is now advisor to the UP President for Academic Affairs and Research Development. Okay, next week, we've got a great topic next week. So we are going to talk about an outbreak of dengue in Region 8. And we will talk about dengue in general. So please join us. I think our speaker is going to be Jean Solante. He was telling me about a study on why we have mortalities. Bakit merong mga namamatay pa from dengue when in fact, even if you do get dengue, you should be able to be saved, no? So we will talk about that. Don't miss it. Jean Solante, and then we're going to have somebody from Region 8. Over to you, Raymond.
Thank you so much, Dr. CUBILLAN, and thank you, Dr. Susie. You will see in our evaluation poll that at least 92%, 91% of those who were polled or participating in the evaluation poll really strongly agree with all of the statements that are put in there. So thank you so much to the Department of Emergency Medicine of the Philippine General Hospital po, no? But before we conclude our program, All Stop COVID Deaths webinars are archived for viewing in the TVUP YouTube channel for your convenience. Just go to youtube.com/TVUPPH for you to see all 133 webinars. And then after today, it will be 134 po, no? We also understand that everyone very busy. We have selected presentations that we will feature in its entirety. Lovingly called po SED Shorts, also found in the TVUP YouTube channel. So if you have maybe like a minute or a minute and a half for you to be able to gain these nuggets of wisdom, clinical pearls if you will, please make sure to watch this SED Shorts po natin. So that wraps up our webinar for the week, and we look forward again to your company next Friday from 12 noon to 2 p.m. It's a day.
Together, we can stop COVID deaths.
So keep safe, keep healthy, and see you online.